Hello, everyone. Thank you so much for joining us for our Implementation Science Seminar. I'm very, very excited to welcome Dr. Cattamanchi, who's a professor of medicine and epidemiology and co-director of the Partnerships for Research and Implementation Science for Equity, the Prize Center at UCSF. His research focuses on two thematic areas: the development and evaluation of novel diagnostic tests for tuberculosis and improving the delivery and uptake of evidence-based care for TB in high-burden countries. He's the PI of 5 R01s and 1 U01 grant related to these themes. In addition to research, Dr. Cattamanchi co-directs the UCSF Implementation Science Program from 2015 to 2021, and is a faculty member at the RISE program, of which I was one of the first graduates. So he's been an amazing mentor and helped me write my first R01 as well, and directs the introductory course at UCSF on implementation science, so the certificate program. He also co-directs the Impact K-12 program, which supports career development of junior faculty pursuing implementation science research in heart and lung disease. So we're very, very excited to have you. And thank you so much for joining us.
Great. Well, thanks, Natalie. I'm delighted to be here. And it's always a pleasure to connect with you and sort of others in your group. So Natalie asked me to talk about some of our work using implementation science to improve the quality of tuberculosis care. And so this is really just going to be kind of a case study of a series of work that we've done in Uganda. I know that you all probably don't think about TB that often, and so I just wanted to start by just reminding us all that there's a tremendous sort of global burden of TB still in 2021. You guys know that TB is one of the oldest infectious diseases afflicting humankind, but despite that, it's really just been a silent sort of epidemic, or really sort of pandemic before COVID, and now again, sort of I guess we can say after COVID, or in the kind of after 3 years of COVID. TB is again the leading cause of infectious death worldwide, with an estimated 1.6 million deaths annually. It's the leading cause of death also in people living with HIV. And drug resistance, or multi-drug resistance, is an increasing problem that we're all going to have to sort of think about sort of moving forward. One of the big challenges in TB and that our group focuses on is sort of lack of access to diagnosis, which really contributes to not only mortality, but also sort of ongoing transmission and sort of the increased sort of case burden of TB in affected communities. Of the estimated sort of 10 million TB cases every year, only 5.9 million are actually sort of detected and treated and reported to public health authorities, leaving sort of a substantial gap of nearly sort of 70% of cases not being detected. The problem is even more pronounced in children, where of the estimated about 1.1 million cases, only 385,000, or about 30 to 40%, are actually sort of diagnosed and treated. Part of the reason for this is, that we've had very little innovation in sort of TB diagnostics over the last really 150 years. At the basic levels of the health system, where most people present for care in high burden countries, there's really no diagnostic test available. We rely on sort of screening for symptoms and referring people to higher levels of care, or for empiric sort of treatment. At sort of a little bit higher levels, like areas where you have a basic lab, microscopy centers, you really just have very limited diagnostics. Sputum smear microscopy is what's been used worldwide. It's really been used for the last 150 years, right? And you've seen with investments in COVID, like what we've done with diagnostics, in such a short time, and none of that has really happened sort of for TB. And then at higher levels of the health system, we still rely on culture, which takes a long time and is really sort of limited in terms of capacity to be done for routine testing. And so this lack of diagnostics has really contributed to this inability to actually get people diagnosed and linked to treatment. In 2010, there was this new assay called the Xpert MTB RIF assay, which was developed by Cepheid, a company here in the US, which was really sort of described as a game changer. It was the first sort of molecular test for tuberculosis to be endorsed by the World Health Organization, and this was again in 2010. The innovation here is that it was a semi-automated PCR platform, and so all that needed to be done was for a sputum sample to be collected, a reagent added to the sputum cup, and then that mixture sort of inserted into a cartridge. Then all of the steps of PCR were automated in the GeneXpert platform, with a result for TB as well as rifampin resistance provided in less than 2 hours. The other thing is that this test was much more accurate than sort of smear microscopy, with a sensitivity of 85% and really high specificity. And so predictably, the response was significant donor and country investment in this technology, because as we all know, technology solves all problems. And there was really rapid scale up in high burden countries. At the time we started this work, the graph on the bottom right shows how quickly donors and countries sort of invested in these platforms, with obviously in 2010, when it was first identified, obviously no sort of devices, but then very quickly over the next 5 years, tens of thousands of these platforms and millions of actual tests and cartridges being deployed in high burden countries. And this has really only continued to accelerate sort of over the last 5 years. The area where we do the work I'll present today is in Uganda, and Uganda has really been a leader in scaling up GeneXpert testing. They've had really rapid sort of scale up, and they, like many high burden countries, have deployed this using a hub and spoke model. And what I mean by that is that this test still requires a continuous power supply. So it's mainly deployed in sort of higher level facilities, which are shown in the red triangles sort of in the map in Uganda. And then these are linked to more smaller health centers using kind of a sputum transportation sort of system. And so Uganda has established over sort of 200 GeneXpert hubs, testing hubs, and they've procured at this point actually more than 1 million sort of Xpert MTB RIF cartridges. So since when we started this work, in 2015, since GeneXpert was sort of introduced in the country, there were some suggestions that it was actually having an impact, right? There was a nearly 4-fold increase in confirmed drug-resistant TB patients. There was perhaps an increase in the total number of TB cases that were notified annually, going from about 40,000 to more like 45,000 from 2010 to 2015. And then a higher proportion of cases that were actually bacteriologically confirmed or diagnosed rather than empirically treated, going from about 60 to 65% up to greater than 70%. But despite these suggestions, I think there are a lot of unresolved questions, right? How well are these expert referral networks, this hub and spoke model, actually functioning? What was the quality of TB diagnostic care within these referral networks? And what policy changes or co-interventions can further enhance implementation of Xpert and sort of future molecular tests that come along? So we set out to answer some of these questions in a series of studies, which we overall call the XPEL TB, or Xpert Performance Evaluation to Facilitate Linkage to TB Care program. And we kind of had 3 kind of overarching aims. The first was to quantify gaps in TB diagnosis at health centers linked to these Xpert testing sites. Then to identify modifiable barriers to delivery of high quality TB diagnostic services within these referral networks, both at the provider level, patient level, and health system level. And then to develop and evaluate theory-driven interventions to improve the quality of TB diagnostic services. So the study setting, we worked with the National TB Program to select, 16 GeneXpert testing sites. As you can, they're the ones in the red triangles on this map. They were selected mainly to be feasible in terms of being relatively close to the capital city of Kampala, just in terms of being able to travel and collect data. And then also just based on having a sufficient number of cases to be able to sort of evaluate trends and patterns. And then we worked with the 24 health centers that were linked to these GeneXpert testing hubs to collect data. The data collection was sort of very pragmatic. This is often a challenge in high burden countries where we don't have sort of electronic sort of health records. And so what we did was we, because TB is a reportable disease, all health centers that are involved in TB diagnosis and treatment use registers that are authorized by the Uganda Ministry of Health. These include a presumptive TB register to capture people who are considered TB suspects based on having cough or other symptoms. There's a TB laboratory register that records the results of all laboratory testing. Expert requisition forms, which are used to order expert testing and send and transport sputum to the hubs. And then a treatment register where everyone started on treatment is recorded. So we had health center staff take pictures of these registers every week and upload them to a secure sort of REDCap server. And then our study team extracted patient level data. And again, to address issues with missing data in routine data sources, they would call the health centers after reviewing the photos to resolve any sort of data queries. And what we were able to do was really kind of in fairly real time get actual data on all of the sort of testing and treatment that was occurring at these 24 health centers. This is kind of the summary of the first study that we did. This is in 2017, where we just looked at all of the adults who were undergoing evaluation for TB and assessed, to what extent they were actually completing the entire cascade of care. And so the first indicator that we looked at was the proportion of those who were identified as having a TB suspect in the presumptive register who were referred for sputum-based TB testing. Then we looked at if they were referred, how many actually completed the recommended testing, which was either receiving 2 smear exams or a gene expert test. And then last, the proportion who were treated if they were a smear or expert positive, within 14 days. So these are all based on sort of international guidelines for TB care. And these are called the International Standard for TB Care, ISTC. And then last we calculated what was the probability that, people would complete each of these steps if they were someone with TB entering these systems. And what you can see is that, you kind of see consistent drop off at each step in this cascade, with only 79% being referred for testing, 56% completing testing if referred, and 75%, starting treatment if they were a smear or expert positive. So overall, when you put this together, what it means is that you only had, if you were someone with TB entering these health systems, you only had a 42% chance of being referred for testing, completing testing, and being diagnosed and being treated, which is obviously sort of abysmal sort of quality of care. In terms of expert testing itself, despite this large coverage of expert testing across the country, what we were able to show was that only 20% of patients were actually referred for expert testing, including only 33% of people with HIV for whom this was supposed to be a first-line test, and then very few of those who did not have HIV. When people were referred, it was still being done after smear microscopy. So only 6% of patients were referred for expert as a first-line test. And then critically, only half of those who were expert positive were actually being linked to treatment. And so I think our summary was that, this is something that's often an issue in global health, where people measure coverage of services, right? How far are services actually distributed? But, coverage doesn't equal sort of actual high quality care being delivered. And, you really need to sort of look beyond just sort of coverage to understand quality and gaps in care. So our second aim was to understand the quality gap. And here we use the theory of planned behavior as a conceptual model. I think many of you are probably familiar with this. And what we were focused on was sort of case detection and treatment as our ultimate outcome, and postulated that, adherence to guidelines would ultimately result in improved case detection and treatment, and that guideline adherence was mediated by intention to follow the guidelines, which, per this theory, is based on knowledge and skills, attitudes, social norms, and self-efficacy of health workers to follow these guidelines. Because we're working in low resource, countries, we also wanted to consider, patient factors that might impact guideline adherence, even if there was intention to follow guidelines, as well as health system factors, the availability of physical and material resources for providers to actually follow the guidelines. So to collect data on these factors, we conducted a series of mixed method studies. They involved key informant interviews with staff at 6 of the health centers we were working at, lots of field observation by our sort of study team that was structured, and then surveys with patients who were presenting for TB evaluation at these health centers. And we conducted standard sort of qualitative analysis to identify themes and key barriers and facilitators to high quality TB evaluation, and then just descriptive statistics for some of the patient costing data. Excuse me. So this slide kind of summarizes a number of studies that we've published, which are shown on the bottom of the slide. And we use the PROCEED framework, which is, as many of you know, another implementation science framework to help design, multi-level interventions. And so we were looking for barriers that were, that we could categorize as either predisposing factors, enabling factors, or reinforcing factors, and wanted to design an intervention that would target barriers in each of these categories. So for predisposing factors, one of the key issues was time and resource constraints, particularly related to the high workload of laboratory staff, which led to low self-efficacy, that they could actually sort of follow the guidelines. And then this pervasive belief that TB evaluation is not urgent, that it was okay to ask patients to come back, a second time or a third time to either complete testing or to be linked to treatment. In terms of enabling factors, both laboratory workers as well as clinicians cited that patients would often fail to return after the initial visit. We documented clearly that a single visit to the health center would cost up to half of a patient's sort of median monthly income in terms of travel and time and lost wages. And then they also were problems with actually transporting specimens to the expert testing sites with the often sort of inconsistent or delayed availability of specimen transport. And then there was an inability to track and sort of follow up patients to make sure if they had positive results, that they were linked to treatment. And this was due to issues like, lack of airtime to call patients, lack of a vehicle or fuel in the vehicle to actually go and conduct home visits, and so on. And then last, in terms of reinforcing factors, there was really little communication and coordination among staff in terms of identifying and sort of addressing sort of problems with patients completing this cascade of care. And then there was sort of insufficient oversight from the National TB Program and other sort of supervisors who were supposed to be checking in on this work and identify and helping to sort of the individual facilities to solve problems. So these were the barriers that we were trying to sort of address with an intervention. And to do that in AIM-3, we went through an intervention design process to improve this quality gap, looking at evidence where it was available, where others have sort of tried to address similar barriers, consulting with our local stakeholders to assess sort of the feasibility and acceptability of different interventions, and then ultimately to prioritize which barriers to target, select the interventions, and specify how they were delivered. So we came up with, through that process, we came up with, this intervention or implementation strategy. So one is that, there was new technology that we took advantage of. There was kind of the Gene Expert system was a new sort of version of it that was battery operated, that could actually be implemented at lower level health facilities that didn't have continuous power supply. And so we wanted to sort of see if we could actually implement this with high fidelity at lower level health centers in order to reduce workload and to increase the speed and accuracy of testing. Second was a kind of a structured clinic process redesign to facilitate actual same-day testing and treatment of TB. And the goal here was to address the lack of urgency and the failure of patients to return after the initial visit, to really kind of emphasize that diagnosis and treatment need to happen on the same day. And then third, to address issues with communication, coordination, oversight, we implemented a very basic performance feedback kind of PDSA model where we provided a monthly report card to facility staff, tracking kind of the key metrics that I described, and teaching them to just review the metrics, discuss them at their staff meetings, identify sort of basic plans for changing processes, and then reassessing the metrics to see how those work the following month. So kind of a very basic, quality improvement system that we thought was feasible with oversight from the district TB supervisors in each of the districts. So we piloted this intervention first in just a single arm interventional trial. And this was, again, at the same sort of 6 health centers, looking at this time around a little more than 1,200 adults were undergoing TB evaluation. Actually started at 4 of these health centers. And what we were able to show was that there was dramatic improvement in each of the same metrics I showed you before. So this time with 99% of those identified as TB suspects being referred for sputum-based testing, nearly everybody completing testing if they were referred, and 85% of those diagnosed with TB actually being linked to treatment. And so now sort of the cumulative probability of being diagnosed and treated was sort of improved from less than 50% before to 85%. So overall, in terms of expert utilization, we also showed that there was high uptake and reach, right? So 91% of those who had smear negative results were actually receiving expert testing. And then there was high fidelity in terms of people who were expert positive, now from going from less than half to now more than 3/4 actually initiating treatment. So based on these pilot data, we were able to have a cluster randomized trial that was funded through NHLBI. And the overall objective here was to evaluate the effectiveness, implementation, and cost effectiveness of the XPEL TB strategy at community health centers. So again, it looked at this kind of the multi-component diagnostic strategy that I described, which included on-site molecular testing as the first-line test for TB, process redesign to streamline, clinical laboratory and pharmacy workflows, and then monthly performance feedback. And that was compared to routine care, which was sputum smear microscopy as the first-line test for TB, and then referral of samples from high-risk patients to these molecular testing hubs. And so this was a cluster randomized trial with 20 health centers, 10 in each of the arms. And it included all adults who were evaluated for pulmonary TB. So the goal here was really to reflect routine care. So there was very minimal exclusion criteria. We only excluded those who had rifampin resistance from the analysis, primarily because treatment of drug-resistant TB is not done at lower-level health facilities. All those patients are referred to a handful of drug-resistant TB centers that are in the country. So one thing a couple of things I just want to emphasize about the trial design and procedures. The one is a use of a public randomization ceremony. This is something we've started to do routinely in all of our community-based clinical trials in Uganda and elsewhere. This really has enhanced kind of stakeholder buy-in and participation. We bring all of the health centers together and then do the randomization publicly with representatives from the health centers, essentially choosing the randomization sequence and then seeing how that results in, kind of in a transparent and fair way, the various health centers being assigned to an intervention and a control arm. As you can imagine, no one wants to be assigned to the control arm in these types of trials. And so this type of a process really kind of has increased buy-in. And also, I mean, we always also kind of provide the intervention to the control health centers at the end, assuming that it's shown benefit. These are ways in which we've really enhanced, participation in some of these trials. The other features I wanted to highlight were kind of what we call sort of really ultra pragmatic features, which I think is really important for assessing, interventions and how they impact sort of routine care. So here we had a waiver of informed consent. We used, only routine data, which, obviously has some limitations, but, also sort of, enables you to sort of look at sort of routine care. We had no, trial-specific changes to usual care. So, for example, in many TB trials, people do chest X-ray or culture, or they do additional patient contact to sort of ensure retention and care. So we didn't really do any of that. Again, we assessed all of our outcomes using the routine data sources. And then we had, minimal contact between our study staff and health centers. There was an initial training visit to train the intervention health centers on the intervention strategy, and at the control health centers just to train them on kind of the guidelines for TB care or retrain them. And then we just had, quarterly site visits to resolve data queries and conduct some nested sort of sub-studies. So the trial outcomes, the primary outcome, in the kind of REAIM framework was kind of in the effectiveness domain, which was the number of patients treated for microbiology confirmed TB within 14 days. And then the secondary outcomes reflect sort of process outcomes related to adoption, implementation, fidelity, and really reflect the cascade of care, right? So our testing, diagnosis, and treatment sort of happening as intended. And so these are really the numbers who are completing testing per national guidelines, the numbers diagnosed with confirmed TB, and then the numbers treated, on the same day, which reflects sort of the fidelity to the intervention strategy, And this is treated overall, including empiric treatment, and then also just for confirmed TB based on an actual diagnosis. So this is the trial flow chart. There were 84 sort of eligible health centers, and 20 were selected along with in consultation with the National TB Program and randomized. One thing to point out, this is by far the largest trial of TB diagnostics. I mean, again, it's because of the pragmatic design. So there were more than 10,000 adults were in the target population during the trial period, and only less than 2% were excluded. The harmonic mean number of patients was actually ended up being higher in the intervention arm, and this was for us a very early signal. I mean, we had 2 years of baseline data at all of these health centers, and the mean number of patients who were undergoing TB evaluation was the same, at these health centers for 2 years. And so right away, this tells you that, with the intervention strategy, more people were getting tested for TB, which is one of the ways in which we thought this would increase diagnoses. In terms of patient level characteristics and comparing the intervention and control arm, as you can see, they were all overall sort of very similar with respect to gender or sex, age, as well as sort of HIV status. And this was, and the randomization was sort of stratified and restricted to sort of help ensure balance. These were the data on the primary outcome. This was a cluster level analysis using negative binomial regression models. And what you see here is that the adjusted rate ratio in terms of the numbers diagnosed and treated for TB within 14 days was significantly higher in the intervention arm. So the rate ratio was 1.56. So overall, on average, you had 342 patients diagnosed and treated for TB versus 220 in the control group. And so this is really kind of quite a large impact on the numbers who are diagnosed and actually sort of treated for TB. In subgroup analyses, we see that this effect is pretty consistent across the pre-specified subgroups that we looked at, which were related to sex and HIV status. So really, you see similarly large increases in the numbers diagnosed and treated for TB within 14 days across each of these subgroups. In terms of secondary outcomes, what we see is, overall high implementation fidelity and improved quality across the cascade of care. So what I mean by that is that, large increases in the numbers who were tested according to national guidelines, who achieved a same-day diagnosis and treatment of confirmed TB, which was a main goal of this strategy. And then at 14 days, you also see kind of improvements in both diagnosis and treatment, although obviously less pronounced than at same days, than on the same day. We also looked at, the cost and cost effectiveness through kind of detailed costing and time and motion and other analyses. And this is just kind of a summary of slides or data from a paper that's currently in press in Lancet Global Health. So overall, what we see is that the cost of Xpert testing in a centralized or decentralized fashion was similar at about $20. But the cost per patient was obviously much higher in the decentralized testing because there was much more Xpert testing that was done in that arm. Overall, in terms of incremental cost effectiveness, and this is really reflects the cost per additional treatment within 14 days, was $687, which is pretty low for most global health interventions. And we also show that that ICER is highly sensitive to the patient volume. So the more patients that are being tested at an individual health center, the lower the cost is per additional treatment within 14 days. And so this is just an argument that at most health centers that test on average even a handful of patients a day, this is sort of something that we would consider to be highly cost effective. So in terms of limitations, I think with any cluster randomized trial, you can think about potential imbalance in the underlying prevalence of TB and other factors by trial arm, given the relatively small number of clusters. As I mentioned, we had a lot of baseline data, and we were able to use that to conduct stratified and restricted randomization to achieve as much balance as possible. This was a multifaceted intervention, so a lot of people want to know what's the effect of just the technology itself. But I think we try to emphasize that, and I think you guys probably agree that technology alone is rarely the solution, and we were really interested in how this technology could be implemented in a high quality way. Generalizability, whether or not the same strategy is applicable in other high burden countries is uncertain, but from our work, I mean, these barriers are pretty common, and this system of care is pretty common in most high TB burden countries. And then last, I mean, I think what I had hoped to sort of also get done by today was to talk about implementation variability and determinants of implementation success at the intervention health centers, but we're still sort of doing that analysis. But I think it's something that's really always important to do to understand the extent to which your intervention strategy and the various components modified their targeted barriers and what contributed to variation in implementation at the intervention health centers. So in conclusion, what I'll say is, scale up of novel diagnostics alone, I strongly believe is not enough to significantly increase case detection or improve outcomes. So this kind of multi-component strategy, which included a novel diagnostic, in terms of on-site expert testing with adequate implementation supports, resulted in large increases in 14-day TB diagnosis and treatment, but also improved quality across, the entire sort of cascade of care. And so we think this is really strong evidence that national TB programs should, consider decentralized molecular testing to close the case detection gap and improve the quality of care. And overall, I hope that, this also shows how implementation science-based methods can be useful for designing and evaluating health system interventions to improve quality of care. So I'll stop there with just acknowledging kind of especially the in-country team that really did a lot of this work. And pictured there is our team in Uganda at one of the study health centers, as well as our partners at other institutions, including Hopkins, Yale, and the London School, who contributed to a lot of the sub-studies that were done, including the costing data. So that's also.
That was amazing. Thank you so much. I think that's such a great example of creating a theory-informed implementation strategy, seeing results, and having it published in high-impact journals as well. So that was really great.